Hey folks, this is Scott Weingart, and you are listening to the MCrit podcast. Just got back from ACEP, that's why this podcast was delayed a week. Had a great time. If I got to meet you there, it was great seeing you. Today on the podcast, I want to talk about the recognition of posterior stroke, specifically cerebellar infarcts. Why this is important is sometimes these present quite subtly. If you miss these and send the patient home with a prescription of meclizine, it does not work out so well, given the tight real estate of the posterior fossa. So what we're going to go through today is how to take a patient with seemingly isolated vertigo and decide if they have a benign peripheral condition or a serious cerebellar infarct. Now, a name you're going to keep hearing about throughout the podcast today is David Newman-Toker, who is an associate professor of neurology at Johns Hopkins. And he has put out article after article on this exact topic. And these articles are all going to be in the show notes. And the first article basically says, in the ED, we're not that good at separating out the various causes of vertigo. A lot of the patients just get labeled as benign positional vertigo and get a prescription for meclizine, and those two are already discordant, and get sent home. I'm not going to be talking about benign positional paroxysmal vertigo today, except to say that it is a intermittent vertigo, meaning patient moves their head, they get vertigo, it fades, and they are free of symptoms until they move their head again. That's very different than consistent vertigo. And if you have persistent vertigo, then you're dealing with a condition called acute peripheral vestibulopathy, APV. Now, most cases of APV are either going to be neuritis of the vestibular nerve or labyrinthitis, which is essentially the same thing with some hearing symptoms added in. But what it could be is a cerebellar stroke. And so we're going to talk about how to differentiate between those two. Now, one of my mentors, Andy Jagoda, always told me that a cerebellar stroke will not present with isolated vertigo. That if all you have is isolated vertigo, you don't need to worry about these patients. And that's true if you're doing the kind of neuroexam we're going to talk about today. And it is not true if you're just doing your standard ED neuroexam. The stuff you have to look for on these patients with vertigo is very different than your typical screening neuroexam. So first of all, I'll say a hallmark of badness for me is ataxia, especially gait ataxia. If your patient can't walk without assistance, that's usually something bad. Not many of the peripheral causes give the patient the inability to walk at all. They might stumble a little, they might lean on the wall for support, but they'll be able to walk. They also might have truncal ataxia. They might not be able to even sit up in the bed. That is not a benign cause of vertigo. So we talked about ataxia, and the next set of things you look for are encompassed by the acronym HINTS. 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 This was talked about in an article, again, by Dr. David Newman-Toker, and the first author was Jorge Cata. That article, of course, is in the show notes. What the HINTS exam consists of is 3 parts. Head impulse testing, which we'll talk about, nystagmus, which we'll talk about, and test of skew, which of course we'll talk about. So let's start off with head impulse testing. It's also called head thrust testing. And the idea behind this is you have a reflex called the vestibular ocular reflex. And when you turn your head sharply to one side, it's what allows your eyes to stay focused on whatever you were looking at. So if you try it right now, stare at something, turn your head rapidly to the left or right, and you'll see your eyes stay right where you want them, even though your head is rapidly turning If someone had a peripheral vestibular problem, that reflex is going to get knocked out because the vestibular nerve is not functioning properly. So the idea behind the head impulse test is you actually want it to be abnormal in these patients because that reassures you that their vestibular nerve is the issue. So you want them to lose that vestibulo-ocular reflex. If the vestibulo-ocular reflex is intact, that's a problem and should make you very worried about the possibility of a cerebellar stroke. The way you perform this exam is you have the patient fix their eyes on your nose. You tilt their head a little bit forward, about 20 degrees. You place their head between your hands, and then you rapidly turn their head in one direction, about 20 degrees, and then you bring it back to center. And then you go and alternate the directions you're turning their head. If the reflex is normal, their eyes will stay fixed on your nose. If the reflex is abnormal, what's going to happen is their eyes will move in the direction you turn their head, and then they'll refixate on your nose. So what you're going to see is what's known as catch-up saccades. The eyes have to reorient to your nose. So instead of the eyes staying stationary as the head moves, you'll actually see the eyes moving to refixate. That's an abnormal test, and like I was saying before, abnormal test is reassuring of a peripheral problem. Now there's some subtleties to doing this testing. I'm going to have a video put out the same time as this audio podcast with the actual procedure, and videos courtesy of Dr. Newman Toker. So that was the head impulse testing, the HI of the Hintz mnemonic. The next thing to look for is a particular kind of nystagmus. Now most ED folks already know vertical nystagmus, bad. But you're not off the hook just because the nystagmus is horizontal. Benign peripheral disorders give nystagmus that beats quickly in only one direction. And so you have the patient look to the right, and it'll beat to the right. And then you have them look to the left. And if it's going to be any nystagmus at all, it's going to keep beating to the right. And you have them look up, it beats to the right. You have them look down, it beats to the right. Or it could be the left. The point is, it only goes in one direction. Now, on the other hand, if you have the patient look to the right, and there's right beating nystagmus, and then you have them look to the left, and there's left beating nystagmus, that's known as direction-changing nystagmus. That is bad. The last part of the Hintz mnemonic is test of skew. And what you're looking for is a vertically disconjugate gaze. You could actually have the vertical alignment of the eyes skewed. Now in some patients, you could just look at their eyes and you'll see one eye is higher than the other, and that makes it easy. Most of the time, though, they could overcome this vertical misalignment by fixation. So you actually have to do what we call the alternating cover test. And what that consists of is you have the patient again look at your nose and you cover one of their eyes. This is going to prevent the covered eye from fixating. Then you rapidly remove your hand, and what you'll see is that eye that is vertically misaligned coming back into alignment. So just like the catch-up saccades of the head impulse test, you're seeing the realignment as the eye is fixating on your nose. That's abnormal. And you just alternate eyes and look for that realignment. Now, if the patient complains of binocular diplopia, that's also a sign of a vertical skew deviation. So how do we put this all together? If you have a patient with isolated vertigo, but any of the Hintz acronym stuff is not what you'd expect it to be, then if you have neurology available, get neurology involved. Don't have neurology, but you could get an MRI. These patients need an MRI. You could still start off with your non-contrast head CT. Sometimes it'll be positive, but usually in these cerebellar strokes, you're not going to see anything. So get an MRI. If you can't get neuro or an MRI, these patients probably deserve transfer to a center that does have one of those two. I will also say, if you're unsure of your neurologic exam and you have that 75-year-old with hypertension and diabetes, it might be worth it to get someone who could really do a good neurology exam, unless you're very confident of your skills. So we talked about the HINTS acronym. It stands for head impulse testing, nystagmus, and test of skew. You want your head impulse test to be abnormal to reassure you. You want your nystagmus to be fast beating in only one direction to reassure you. You want perfect vertical alignment of the eyes to reassure you. If anything is not reassuring, your patient could have a cerebellar stroke, and you better take action. All right, I'm going to leave the audio here. I'm going to go now to the video. So now is the time to press play on your iPod and check out the video. I also have a fantastic review article by James A. Nelson on differentiating peripheral and cerebellar causes of vertigo. So check that out in the show notes. Thanks to Dr. David Newman-Toker from Johns Hopkins for all his help on this podcast. I'm going to have him listen, and hopefully he'll add any comments and correct any of my mistakes. If you get a chance and you haven't already, go to iTunes, give us a 5-star rating. It matters. That's all for this week. Scott Weingart for the MCRIT podcast saying bye-bye.